Okay. Okay. So we've just been introduced to the development of ectasia, and Dr. Bharti has very nicely introduced the subject. And thank you so much for having me on the course, Sudhank, along with the lovely co-instructors who had the experience in the past, and I've greatly enjoyed this course. So no financial disclosures, though I wish I did. So we all know what the keratoectasia is. It's a progressive anterior shift with central steepening, thinning, astigmatism, myopia, irregularity, and then visual symptoms. And it used to be fairly common. It has reduced, but the number of surgeries have gone up so much that we still do see our occasional ectasia patients, but it used to be almost 0.5% going back into the early years of refractive surgery. So what are the causes? And so we were thinking of thin stromal beds. We've looked at that aspect with PTA coming in, undetected topographic abnormalities which have slipped under the radar, biomechanical properties which have largely been overlooked over at least the first 2 decades of refractive work, but are now slowly coming to the forefront. Some studies suggesting that there's a late stromal melting, but there was no underlying inflammation that has rarely been considered to be the reason why this happens. So one thing that seems to be fairly certain, which is the current concept for ectasia development, that it is a focal weakening in the corneal structure, which then starts a cycle of biomechanical decompensation, leading to a localized thinning and steepening. And there is a two-hit hypothesis, which proposes that there is an underlying genetic predisposition, and this is coupled with an external or an environmental factor. And this could be rubbing, as in keratoconus. It could be a surgery. It could be contact lens use. So any of these could be the second hit that has then made that underlying genetic predisposition worse and made it become manifest. So the changes in curvature, elevation, thickness, which we can see on the pentacams and the OCTs and the other devices, are essentially secondary elements, while the primary abnormality is related to the direct biomechanical weakening. So it comes as a bit of a surprise as to why biomechanics hasn't actually taken the forefront in the ectasia detection. So the ectasia development occurs due to a chronic corneal biomechanical decompensation or weakness, resulting in stromal thinning and corneal protrusion. And the advent of 3D tomography, such as the OBSCAN and the Scheimpflug imaging, is proven as a significant advancement to characterize the corneal shape beyond front surface topography. But these screening tests are limited to corneal shape, and the biomechanical assessment has now been possible with the ORA in the last 15 years, and now the Corvus ST over the last decade. And direct clinical biomechanical evaluation is now recognized as paramount, especially in the detection either of mild ectasia cases and the characterization of the susceptibility for ectasia progression. So the segregation of these high-risk individuals preoperatively who may experience corneal ectasia after LASIK from patients who can undergo the procedure safely is of crucial importance. And this we can do by looking and understanding what biomechanics really is. So look at this coil spring, which is the automotive shock absorber, and it comprises of a spring element, which is here, and a viscous damping element, which is here, the shock absorber, so to speak. And the strain or the deformation that one gets is directly proportional to the stress. The more the stress or the applied force, the more is the deformation. It is independent of the length of time or the rate at which the force is applied. Whereas the viscous resistance, which comes from here, is a resistance based primarily on the speed at which the force is applied. And it is these two principles in the corneal tissues which allows us to look at the corneal biomechanics. So tonometers essentially make static assessments. That means they will make an assessment on the corneal surface when applanation has been reached, which is a steady state. Whereas the ORA and the Corbis ST make dynamic measurements, and they monitor the entire movement of the cornea in response to this air impulse. And that is what allows us to capture these abnormalities. So what is the problem with these corneal thickness based assessments? One is that all corneas are not the same, and thickness is not resistant. So if you take, say, a piece of pine wood and a piece of oak wood, the same force that would bend pine will not bend oak. And that tells us that thickness is not really the only thing that is in this area. So the objective to produce a minimal ectasia and to minimize the potential by leaving a minimum thickness of cornea in place is not entirely satisfactory because of the unknown biomechanics of that particular cornea. And thickness is not strength, as I've said earlier. There may be soft corneas which require larger residual stromal thicknesses to be left behind, and there may be hard corneas which may be able to tolerate more aggressive ablation safely. Now let's look at this population. So here's a population in red where there is an average preoperative hysteresis seen by a biomechanical device like the ORA. And we know that the CH goes down along with the CRF following LASIK. But you can see in this particular patient here that this average, the pre-LASIK CH is lower than the average population post-LASIK CH. So this is the patient you need to be really concerned about and actually avoid considering him for a refractive procedure. So when one looks at the values that come out of these machines, we note that as the air pulse goes up, there is an in-signal peak when applanation takes place. Then the cornea becomes concave as the pressure of the air builds up. And then as the pressure of the air goes down, the cornea comes back from its concavity to give you a second applanation phase, which is the out signal. And the difference between these two, in and out, because of the lag behind effect, is called hysteresis. So let's look at a case report. So here's a patient who's 22 years of age. She has about a 3.25 diopter of refractive error. The only thing here was the 47K on the left eye, which was slightly outside the range, which should have made us look at this more carefully. A topography suggested that there may be a suspicion of a subclinical keratoconus on the left eye. The pachymetries were low, but look at the CH and the CRF values. These are way below the normal 11s and 12s that we see. And this patient would certainly be a high risk for a keratoectasia, especially if a LASIK is considered. Another patient with a slightly higher PA, but absolutely normal case, a little bit of corneal distortion, very good corneal thicknesses again, but again, look at these CH values, way below normal. And this patient would again be at risk for developing ectasia. The KMI values, which is the keratoconus match index, which is something that the ORA gives us, also has value. And here you can see both on the left eye in case 2 and on both eyes in case 1 to be fairly abnormal. And these are the patients one should watch out for. So the signal quality as well as the signal configuration has a lot of value in assessing these patients. It's not just CH and CRF, which are numbers. And again, people will ask for those magic numbers where how to take a decision, but one must look at the signals. And you can see here, this is the beautiful normal cornea signal where there's a good signal amplitude, good clean points, fairly smooth, and the signal is flat with the same amplitude on both sides. When we look at the keratoconus patients, other than the CH and CRF values and a thin corneal center, there is low amplitude peaks. They are sharp and thin. There's a raw signal bounce that happens because of the tremulousness of the cornea, and there is a noise in the raw signal. And these can actually reduce the repeatability of these values as well. In a subclinical keratoconus, again, one can see that the CH and CRF are both are low, as well as in severe keratoconus where there is absolutely no values available. The moment the air puff hits the cornea flattens, and thereby you get hardly any signal amplitude at all. So here you don't have to look at numbers at all. No question, this is keratoconus. So identifying ectasia signals also, they start to mimic the keratoconus where there is a low amplitude, noisy and messy signals. The signal quality does not improve over time and often is present in one eye and not in the other. So if one looks at the problems here, both keratoconus and normals have a significant degree of overlap in numbers. And that's one of the problems with corneal hysteresis. This is the keratoconus max inject, which tells us how the keratoconus patient is likely to be more of a problem here. The KMI here is 0.69, which is subnormal. The new Corvis ST is a Scheinpflug technology instrument, and this has generated the biomechanical corrected IOP, like the IOP-CC, the Corvis biomechanical index, and now combined with the Pentacam, the tomographic biomechanical index and the biomechanical glaucoma factor. Just to summarize, mild ectatic cases typically are at very high risk for iatrogenic keratoectasia if an additional biomechanical weakening is induced. Corneal topography and tomography have increased our ability to identify these ectasias at earlier stages. Direct clinical biomechanical measurement is recognized as paramount for augmenting the specificity and sensitivity for identifying cases with this kind of susceptibility. And the corneal biomechanics with the availability of these new machines is becoming a key evaluation in ectasia detection and filling the missing link in the screening for high-risk refractive cases. Thank you very much for your attention.